So, if I just talk about initially what harm reduction is, it approaches that seek to prevent or reduce the overall level of drug consumption. So harm reduction can often be arranged in a hierarchy with more feasible options. So you're working with people who are very sort of low threshold, you're working with people who are on the streets, you're basically working with people to keep them alive. So part of harm reduction isn't, as people kind of see, is opposed to abstinence. Abstinence, if it's okay, is a desirable option for that individual. But predominantly, you're working with that individual to keep them alive, to keep them safe, and to reduce the blood-borne viruses, abscesses, and various other things as well. So I talk about this the history of harm reduction in since the 80s. Majority of the services were predominantly before the 1980s. We're looking at sort of direct as curing addiction. There was that whole idea, we are going to cure addiction. And the church, the Catholic Church had a significant input, especially in Ireland, and it still does today in some respects, and some drug services, into actually curing addiction. That was the main ethos. So of course, when that came about, we had the whole epidemic of HIV in the 1980s, mid-1980s, where people were, injecting drug users were surfacing with this HIV, people just didn't know what to do. So, I suppose in response to that, the Merseyside Harm Reduction Service was actually the first service to actually set up a needle exchange service in Liverpool. That's actually the photograph it was actually set up in, where the needle exchange was actually set up in. And the actual first conference, I suppose harm reduction conference per se, international one, was in 1990. So a lot of the, I suppose, majority of the, harm reduction came out initially from the Merseyside. So when you look at the Irish group, which we're looking at in a minute, the Irish context would be predominantly coming from the UK model. So if we look at what kind of harm reduction everything came in, really, the NACD, it's about 2002, 2004, I think it is. They were commissioned under Action 100 of the National Drug Strategy. This was actually reviewed and prepared by a team of Dublin from DCU. And it's clear from this is going back to 2002, 2003. This is what people remember that. It's clear from this review that our Irish harm reduction services need to be more flexible and be available to all health boards as they were in all areas of the greatest need. At the time, the areas of the greatest need was perceived to be the Dublin. That's where everybody was, all the HIV, I suppose, the majority of the HIV individuals were actually were coming to, were going to the services. However, they were going to those services in Dublin because the services were in Dublin. If you look at the southwest, we're only just getting needle exchange services into the southwest into areas now. So predominantly the needle exchange services have been Dublin based or just outside of Dublin, like Kildare in that area. So again, going back to this, it says alternative approaches should be considered to support the expansion of harm reduction services such as community pharmacy and needle exchange. I'm one of the trainers on the community pharmacy and needle exchange, and that's only just been implemented in the last year and a half. It's going very well, I have to say, but bear in mind, this is 2002, 2003. We're now in 2000, pharmacy and needle exchange was actually introduced in 2011. So you can see that there was a huge gap, even though this was actually an official recommendation. Harm reduction services should have the flexibility to cater for all the provision and exchange and a range of drug use paraphernalia to reduce the risk of contracting drug-related infectious diseases and other harms. So there's a recognition that exchange services reduce the blood-borne virus and reduce the harms to the individual and to the communities. They also say that hepatitis C in particular is a very resilient organism, and there's an implication for showing any piece of drug taken equipment. Now this is in 2002, 2003. 2012, we've only just got, literally the last few weeks ago, we only just got our Hep C strategy implemented in this country. You talk about 10 years, and there was recognition then. I mean, this is an official document, there was recognition then. So what actually happened was HIV suddenly came onto the agenda, and Hep C kind of got put to one side. And now there's a huge, we see in a minute, there's huge numbers of people with Hep C. So going on to what drug consumption rooms are, they're professionally supervised healthcare facilities, and they provide a safe and more hygienic environment for drug users. Drug consumption rooms are defined as legally sanctioned low-threshold facilities which allow for the hygienic consumption of pre-obtained drugs under professional supervision and in a non-judgmental environment. So they're pre-obtained, they're not given by doctors and nurses in the services, as some people think. They are pre-obtained. When they go in there, they are legally allowed to inject in those services. And it's also under professional supervision, so you have doctors, you have pharmacists, you have trained, qualified nurses to actually work with those individuals. You also have trained project workers as well. And it's in a non-judgmental environment.
Do they test the purity of the drugs for them?
Not that I know of. However, saying that, there's not been one recorded fatal overdose within any of the injector facilities. But they all have to lock some as well, so I can cover later on if we need to. So this is really, really, really important, because when there's an element of risk of overdose for an individual, it's down to the drug setting. So the more risky the setting, the more at risk the person is of overdose. So the effect of the drug is determined by its pharmacology, its administration, and the person taken in its context is taken in its drug setting. These factors affect the risk of the harm of drug use. So the drug setting, so if you're injecting in a safe environment, if you're controlling your injection in a safe environment around people, you're less likely to overdose. If you're injecting safely in a clean environment, then you're reducing your risk of abscesses, unblockable viruses, collapsed veins, and everything else that goes with that. So they're defined as protected places and high services. They're protected so that you don't get police officers going in and raiding these places and rounding them up and arresting them. So a protected place for hygienic consumption of pre-obtained drugs in a non-judgmental environment and kept under supervision of trained staff. So you're working, always will be working with trained staff. Okay, these are just two examples. Both inside in Vancouver, some of you may have heard of, and there's the Sydney Medical Supervisor Injection Centre as well. You can see how these. There's no real difference between them, and how they're set up. And as you see the evaluations later on, they're very much the same as well as the evaluations. But people just basically come in. There's a worker normally stands there, and basically this is their area. And once they've gone in, sometimes they'll have different areas where they can actually go and sit down afterwards. They've got a cup of tea or a cup of coffee. They can rest there for a while. If they're at risk of overdose, then the locksmith can be issued or an ambulance can be called. So if we look at, look at it from a European perspective, you've got Spain, Germany, Norway, Spain, and France will be coming in. As France have actually been announced recently that France are actually going to be piloting the injecting facilities, hopefully next year in 4 cities: Marseille, Paris, Bordeaux, and Toulouse. So they're coming on board as well. So They do vary. They vary from region to region. Some services will actually link in with other services. You might have something like, I don't know, an example, big drug service like Analytic or Moses Key. So they could actually, they might just be attached to that service or an area, that's working within that area. I said there are 85 drug consumption rooms. Now, there's drug consumption rooms and there's safer injecting facilities. And so drug consumption rooms are rooms where you can actually inject and you can smoke. And it really depends on the prevalence. I mean, some areas will actually have more smokers than injectors. Some people just, some areas will just be literally focusing on the injectors. So it really depends on the need of the area. But majority say that these DCRs would have, these DCRs or supervised injection facilities would have about 85 across Europe at the moment. The reason why that's actually in blue, what I've actually done for you, I hyperlinked all the articles, which you can, so if you want to download this presentation afterwards, you can download it. So all these articles are actually hyperlinked, so once you click on it, it'll take you to the actual reference as well for you. So, if we look at the UK picture, there's loads and loads of information around. A bit of a guru, actually, a friend of mine called Neil Hunt. He's done an awful lot of work around and research around injecting facilities. And you see, there's guidance and standards for the establishment and operation of drug consumption rooms in the UK, and there's also an indicator of the need of drug consumption rooms in the UK. So you've got the standard operation procedure, you've got the establishment of an operating procedures of drug consumption rooms, and you've also got the need for drug consumption. You've got needs analysis and indicators for communities, which can be shown as well. So if we look at, the legal implication of it. It says Article 4 of the 1961 Convention, which obliges the states to have signed up to the Convention, which in Ireland we've signed up to. The possession of drugs is limited exclusively to medical and academic purposes. In Ireland, obviously, we've signed up in 1997 and 1984, which ensures the island's compliance under international law. So that's what everybody sort of quotes. However, the UNDCP, which is like the Legal Affairs Department for the UN, said it might be claimed that its approach to SIFs, which is safe injection facilities, is incompatible with the obligation to prevent the abuse of drugs. It should not be forgotten, however, that the same provisions create an obligation to treat, rehabilitate, reintegrate drug addicts, whose implementation depends largely on the interpretation of the parties of the questions concerned. However, if, for example, the purpose of treatment is not only to cure pathology, but also to reduce the suffering associated with it, then reducing drug use of users, exposure to pathogenic agents such as HIV and hepatitis C should be considered as treatment. So what I'm trying to say tonight is that supervised injecting facilities should be seen as a treatment option. And that's something that I suppose I'm kind of more and more passionate about. Because if you have doctors and nurses, it's almost like you can see it as a treatment option. I'm putting to one side the whole thing around injecting, having parent-assisted treatments. Because I mean, there's a kind of you hear it's really, really annoying when people say the drug consumption rooms and they put this sort of parent-assisted treatment, which is like the diet morphine or something like the riot trials in the UK, so they put them together. And that's what they think psycho-injecting facilities are. They're completely two different things. You're dealing with completely two different types of cohorts of people. You're dealing with supervised injecting facilities. You're dealing with chaotic people. Most of them would be street homeless people with mental health issues.